The High Voltaren, a case of diclofenac-induced necrotizing autoimmune myopathy, or NAM. NAM is a rare subtype of idiopathic inflammatory myopathy characterized by proximal muscle weakness, rhabdomyolysis, and an active necrotizing myopathic process on biopsy. Diclofenac has been implicated in causing rhabdo, with 8 documented cases in literature. Onset of disease about 3 to 7 days after starting diclofenac, with symmetric proximal muscle weakness. In severe cases, dysphagia and respiratory muscle weakness can also be present. In our patient, a 50-year-old female with no significant past medical history, she presented to the ED with progressively worsening bilateral upper and lower extremity weakness, which was present for about 3 days. About 2 to 3 weeks prior to presentation, she developed lower back pain, for which she self-treated with over-the-counter naproxen. However, when symptoms did not improve, she went to an outpatient clinic and was started on diclofenac, 75 milligrams BID. About 2 to 3 days after starting the medication, she developed weakness in her arms and legs. She was experiencing difficulty combing her hair, had to crawl up the stairs, resulting in multiple bruises on her shins. She also started developing some dysphagia and dyspnea, and as the weakness continued to worsen, she went back to the clinic, where blood work revealed a CK of more than 12,000. She denied any use of statins or herbal or protein substances. The patient was then admitted for further workup and IV fluid resuscitation. When she presented, her vitals were stable, physical exam significant for reduced strength in both lower extremities, with demonstrable weakness in both deltoids as well. Multiple ecchymosis were noted on both shins. Lab significant for CK greater than 12,000, SED rate of 45, transaminitis, elevated troponin, and reactive thrombocytosis. All imaging studies were negative. The patient was then admitted for rhabdomyolysis secondary to unknown cause, with primary suspicion on diclofenac being the offending agent. The initial workup ruled out a thyroid issue. An autoimmune panel for polymyositis, dermatomyositis was sent out, which returned negative for all, including ANA, anti-SRP, and anti-JO. Other workup, including hepatitis panel, which was done for the transaminitis, returned normal. ACS rule-out was completed with troponin monitoring and serial EKGs. The CK gradually trended down with hydration. A quadriceps muscle biopsy, however, revealed active necrotizing myopathy. It showed basic features of an active necrotizing myopathic process with individual fiber necrosis and regeneration, not associated with any significant inflammatory infiltrates. Gradually, the patient's strength recovered after she was started on steroids and undergoing rehab. The final diagnosis was diclofenac-induced NAM. So NAM is mediated by an autoimmune process triggered by a toxic insult. It can be caused either by drugs, viral infections, cancers, or even connective tissue disorders. Statin use is by far the commonest known risk factor. Diclofenac, however, is now being recognized as a cause of rhabdomyolysis, with data suggesting a causal link. The exact mechanism remains largely unknown. However, accumulation of NSAIDs in skeletal muscle is hypothetically thought to initiate the toxic insult. For this reason, judicious use of NSAIDs is advised, since somewhat innocuous medications can sometimes have terrible side effects. Thank you.